Good afternoon, everyone. Welcome to the our webinar today. And this is a great pleasure because it's our first hybrid webinar for CanPath. So we're very happy to be beginning our hybrid series. And so welcome to all of those online and to those of us who've joined us here in person. So I'm Dalla. I'm the National Scientific Director for CanPath, the Canadian Partnership for Tomorrow's Health. I'm also a faculty professor here at the School of Public Health and in the Faculty of Medicine at the University of Toronto. So welcome and thank you for joining us. Today, it's a great pleasure to introduce Dr. Victoria Kirsh, a scientific associate at the Ontario Health Study, one of CanPath's regional cohorts. She previously had research appointments at Yale University and at the NIH, National Cancer Institute, before moving to Toronto, where she joined us here both at the School of Public Health and at the Ontario Health Study. Vicki leads and supports research activities using OHS data, mentors trainees for us at the OHS and at the Ontario Institute for Cancer Research, where the OHS is hosted, and helps support and builds collaborations with the scientific community. Following today's presentation, we'll have a Q&A period, which I'll be leading or chairing. And if you have any questions for Vicki, please use the Q&A button at the bottom of the Zoom window, or raise your hand or if you're in the room. So I'd like to start off with a land acknowledgement. We acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples, on which the CanPath National Coordinating Center at the University of Toronto now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant agreement, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and Allied Nations, peaceably share and care for the resources around the Great Lakes. With CanPath teams working across Canada from coast to coast, we also acknowledge the ancestral territories that are home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this. So, Vicki, I'm going to turn the mic over to you. Thanks, Vicki.
Everyone, thanks so much for being here. Thanks for the introduction, Philip. So today I'll be talking about real-world insights on COVID-19 vaccine effectiveness and risk factors for COVID-19 infection from CanPath's Support Canada study. And that's sort of a broad COVID-related research platform that's being led by Philip Dalla, and it's supporting a variety of COVID-related research projects, including the one we're presenting today. So weak or waning immune response in tandem with the emergence of new viral variants that are capable of escaping immune response lead to a continued risk of SARS-CoV-2 infection. So the original Omicron variant is gone now, with subvariants of Omicron now circulating. So the dominant strain now is called XBB.1.5. And while we've sort of lost count of the official numbers because people are no longer, not everyone's being tested and not everyone's seeking PCR testing, we do know that the rates of infection have sort of leveled out now in Canada since January, but that there continue to be hospitalizations and deaths. We're seeing about 40 deaths per week in Canada, and the official case counts among those who are seeking PCR testing is that there are about 3,500 new cases a week, but that's obviously an underestimate of the current of the true rates. We know that prior infection is effective against prior vaccination against severe COVID and hospitalization due to Omicron variants, but that it's less effective against symptomatic and asymptomatic mild breakthrough infections. So more than 3 years into the pandemic, the end of the global health emergency notwithstanding, the virus persists and evolves and continues to pose a risk. So the World Health Organization recently declared that, we're no longer in this, international state of emergency, but they indicated that that doesn't mean that we should let our guard down, that there have been an estimated 20 million deaths worldwide during the pandemic, and that, public health preventive measures and vaccinations continue to be important. So the objectives of the current analysis were to measure vaccine effectiveness over the course of the pandemic, and the aim was to untangle the relationship between vaccination status and all of its parameters. So how many doses of vaccination, which brands, time since having received a dose, and risk of COVID infections, while controlling for base infection rates that have varied over the follow-up time, controlling for geographic region and patient demographics, prior infection, and adherence to public health recommendations. And then we also control for antibody levels in a mediation model. The second objective was then to look at some of the other patient participant characteristics and to see how those are associated with this. Our study population includes 22,300 participants from the Canadian Partnership for Tomorrow's Health, or CanPath study, which is a pan-Canadian cohort with over 300,000 participants that includes 7 regional cohorts spanning all 10 provinces. CanPath's National Coordinating Center is based here at U of T's Dalla Lana School of Public Health. So it's a longitudinal population-based cohort, and fortunately, the provision of recontact enabled CanPath to be adaptive in supporting COVID-19 research. And there's also a close collaboration that exists between the cohorts that provided this sort of coordinated infrastructure to do so. The number of participants included in the current analysis for each regional cohort is indicated here. So you can see that there were almost 10,000 participants from the Ontario Health Study, followed by Cardigan and Quebec at 4,500, and then Atlantic Path, the BC Generations Project, and Manitoba Tomorrow. The study includes those aged 19 or older, and women comprise 66% of the study population. So at the outset of the pandemic in April 2020, CanPath launched its first COVID-19 initiative, and that was a questionnaire that was distributed to all participants, and it was completed by more than 100,000 participants. Subsequent to this, CanPath was awarded funding by CIHR and CITF for this initiative called Support Canada. And as part of the second project, serial dried blood spot cards and questionnaires were collected from a subset of participants and tested for antibodies. So these questionnaires and dried blood spot kits were mailed at up to 3 time points during the vaccine rollout. The blood collection began in February 2021 and ended in January 2023. And over this time interval, we captured participants at various stages of their vaccination trajectory. So you can see, for example, that at time point 3, which ran from March 2022 until January 2023, almost everybody had been vaccinated. We have a very highly vaccinated study population. 44% of participants had received 3 doses, over 30% 4 doses, and almost 20% 5 doses. So, and it's important to note here that we start to capture the bivalent vaccines at around the 4th and 5th doses during time point 3, and I'll discuss the implications of that toward the end. The corresponding questionnaires were comprehensive, and they covered all of these domains, and then all of these variables could then be evaluated as potential confounders in our statistical models. So we asked about vaccination status and the brand and date received. And again, because we had these 3 questionnaires, we could modify them as time went on. So originally, when vaccinations were first rolling out, it wasn't apparent that there was going to be heterologous vaccination, for example. And so we could modify the questionnaires to allow people to indicate that they've had different brands of vaccines over time, as an example. And then we could add additional vaccine numbers as it became apparent that people were receiving 3 and 4 and 5 vaccinations. We also asked about COVID test results and dates, and then we even asked if people suspected that they'd had an unconfirmed infection. And again, this was also adapted over time to include rapid antigen test results as they became more widespread. We asked about symptoms experienced, care and hospital-related information, comorbidities, preventive measures taken. So this included whether people, were wearing masks, avoiding leaving the house, attending social gatherings, taking public transport. And in this way, we could control for some of these preventive measures in our models to sort of adjust for the risk of being infected. We also asked about travel, job classifications, and then the impact of the pandemic on social and mental well-being. And then our final questionnaire included some questions about long-term effects. So we used the anti-N IgG serology results to capture unconfirmed infections. So using these dried blood spot cards, we measured 3 different antibody levels and this was done in Anne-Claude Jean-Bras lab. We measured anti-spike IgG, which is a marker of vaccination or natural infection. We measured anti-RBD IgG, which is similar to spike, is a measure of vaccination or it could be positive due to natural infection. And then the last antibody that we measured was anti-nucleocapsid or anti-N IgG. And this one is unique to infection. So it's not, you wouldn't test positive for anti-N based on vaccine only. It's only positive if somebody's been infected. So we then use these anti-N IgG serology results to capture the asymptomatic and unconfirmed infections. And what we did was apply two distinct thresholds for anti-N positivity. One at the beginning of the pandemic when the prevalence was low, and then another one when it was higher. So when the prevalence was higher, we were able to lower that threshold of positivity because as the prevalence of disease increases, true positives are more common, the likelihood of a false positive increases. So this then allowed us to adequately assign participants to their respective infected and non-infected groups. And I've previously presented data showing sort of how we use some of these antibody levels. We looked at how seroconversion rates varied by brand of vaccine received. And for example, we showed that early on, people who were receiving the AstraZeneca vaccine were less likely to seroconvert, and that prompted some of the decision-making around recommending an mRNA vaccine as for future doses. I presented some data showing that these antibody levels were waning a little bit over time, but that booster vaccination sort of effectively restored the antibody levels and sometimes boosted them even higher to what they were before. And then we also saw that some people with underlying conditions like leukemias and other hematological malignancies were less likely to seroconvert just on 2 doses, and they required sort of a 3rd dose, but after that, their antibody levels sort of were similar to other groups. And then for the current analysis, we use these predicted antibodies in the final models to see if they were correlates of vaccine-induced protection, and I'll touch on those results toward the end. So here are data from over 700,000 blood samples collected by 7 research studies, including ours, that were part of a collaboration with the COVID Immunity Task Force. Looking at the graph on the left, the bottom curve, you can see that infection-acquired seroprevalence was relatively low pre-Omicron, really quite low. And then despite vaccine coverage being very high in Canada, the Omicron variant caused a huge increase in seroprevalence beginning in January 2022. And after 9 months, the seroprevalence had increased to 68% by the end of September 2022. So there was some variation by region. If you look at the graph on the left, lower curve, you can see that the rates were consistently higher in Western Canada compared to the Atlantic region. And then the line on the far left shows the seroprevalence estimates for anti-S IgG antibodies, which increased quickly during the vaccine rollout. And this is almost exclusively attributable to vaccination. So anti-S could be a marker of vaccination or infection, but you can see that it was really high even when the infection rates were quite low. So, and those results were really quite sustained over time. By the fall of 2021 and all throughout the Omicron waves, the anti-S seroprevalence was consistently high at 98% or higher. So even though we talk about there being some waning in antibody levels, despite this, the waning was actually, not enough to sort of render these levels, seronegative. They were still quite high. And again, this booster vaccination was restoring levels to their original. And then the graph on the right illustrates the variation in infection-acquired seropositivity by age. So younger age groups are depicted by the blue dots, and the older age groups, the red dots. And you can see that during the Omicron waves, infection-acquired seropositivity decreased with increasing age. So the risk of infection was reduced in the older age groups, but the risk of severe outcomes and hospitalizations throughout the pandemic has always been higher in the older groups. So this ability then to rely on anti-N serology to identify those who were infected proved really to be essential for our analysis. We integrated the questionnaire data that we had with the serology data to classify the source of the COVID-19 diagnosis. So the question here is, how do we know that somebody was infected? Did they have a self-reported positive rapid antigen test, for example? And if so, did they also test positive on our serology results? And so the breakdown is shown here, and note that 62% were ascertained based on antibody results only. And then when we go back to the questionnaire, we can see that 86% of whom indicated that they didn't even think that they'd been infected. So taken together, this means that more than half COVID-19 diagnoses were among those who neither knew nor suspected that they were infected. So our model includes time-varying vaccine-related variables, and this is what makes our analysis particularly unique and robust. We had time-varying vaccination numbers, and again, that could range from anywhere from 0 to 6. We had data on the vaccine brand most recently received, and again, this could change up to 6 times per person. We included an indicator variable for whether the vaccine was bivalent, yes or no, and these assumptions were based on Health Canada's approval date. So it was either September or October, depending if it was Moderna or Pfizer. And these 2 bivalent mRNA vaccines have now replaced their monovalent counterparts. So they've replaced them entirely in the US. The US FDA has in fact deregulated the monovalent versions. And then in Canada, I'm not even sure if the monovalent are available, but there's certainly the guidance is that there's a preference for the bivalent ones. And then we also had cumulative number of SARS-CoV-2 positive tests in the model. So with all of these time varying variables, our data set that originally included 20,000 lines of data, one per participant, quickly morphed into 2 million lines of data. So it really is sort of a unique and very robust data set and analysis. The covariates that were retained in the model were some of the demographics, so age, sex, ethnicity, for example, comorbidities, essential worker status, and some of the select preventive measures as a way to control for risk of infection. So we fit a Cox regression model incorporating these time-varying covariants with adjustment for the baseline characteristics, and then we incorporated regression splines for flexible time trends. We considered two separate time periods, Omicron and pre-Omicron, and we allowed participants to continue to be at risk after their first positive test, and then censored those who weren't infected at the date of the last follow-up questionnaire. We included cases irrespective of their symptoms or severity. We actually only had 40 or so hospitalizations in our data set. That's in part because we had a very highly vaccinated population. And most of the infections, so over 95%, were during the Omicron period. We had to exclude those who were anti-N IgG positive, but who had unknown infection dates, because knowing the date of infection was integral to our analysis. And then we calculated the statistic called vaccine effectiveness, which is defined as 1 minus the hazard ratio, and that indicates the benefit of receiving the vaccine. So the higher the number, the more beneficial. So here we're looking at vaccine effectiveness in the pre-Omicron period. On the x-axis is days since the dose, and the y-axis shows the vaccine effectiveness. And you can see that pre-Omicron, we see an initial delay to vaccine effectiveness, but once it does kick in, there's evidence of really robust immunity, and it reaches about 98%. And these are the statistics that they were showing in some of the clinical trials put out by the pharmaceutical companies. But it's a very different story during the Omicron period. And I think sort of anecdotally, we can all vouch for that, but here's what the data look like. So here's average vaccine effectiveness during the Omicron period. And you can see that effectiveness peaks approximately 45 days after the most recent dose, but it only reaches about 43%. So that's really, quite a lot lower than during the pre-Omicron period. And it wanes very quickly. It wanes to 0 by 4 months. So the shape of that curve on the left was remarkably similar when we analyzed each dose number separately. So here I'm showing sort of an average, what the average curve looks like over all of the vaccine doses, but it really, no matter which dose we stratified by, 3, 4, 5, this is sort of what the curve looked like. And what that indicates is that time since last vaccination is the most important determinant of protection against infection, much more so than the number of doses. And then on the right, you can see that the response to vaccines is in fact mediated by antibody levels, because when we add that variable to the model, we no longer see an effect for vaccination. So we were just looking at binding antibodies, not even sort of a subset of antibodies known as neutralizing antibodies, but we still see this mediating effect of these binding antibodies. So at every dose number, the risk of infection was lower among those who received Moderna's vaccine for their most recent dose compared to those who received Pfizer's. And on average, that risk was 14% lower. We start to capture the bivalent boosters in meaningful numbers by dose 4. And we found that the bivalent boosters restore waning protection, and they seem to broaden protection against the newer variants. So there's sort of conflicting data around this. A lot of data from the CDC suggests that the bivalent boosters are definitely more protective against severe disease. And some studies are finding that they're more protective against infection, and others really are not. You can see with our data, if you look at the forest plots on the left, they show the hazard ratios for the Omicron period and the relative ranking. So the Pfizer vaccine is the reference group. And you can see that the Pfizer bivalent shows a greater risk reduction relative to the Pfizer monovalent, followed by Moderna and Moderna bivalent. The confidence intervals, though, you'll note, are quite wide for the bivalent vaccines, and the differences seen in our study and in others are not as pronounced as we would have hoped. It's thought that this could be due to a phenomenon called immune imprinting, whereby initial exposure to one virus strain effectively primes B cell memory and then limits the development of memory B cells and neutralizing antibodies against new minor variants of the original ancestral strain. So it's possible, therefore, that repeatedly updating SARS-CoV-2 vaccines might not be fully effective because of these immunologic limitations. So here we're looking at average protection after a positive test. So, people often want to know, is prior infection more protective than vaccination? And that does seem to be what our data indicate. We can see that prior COVID infection is more protective than vaccination during the Omicron surge. The risk of infection was reduced by about 90%, and that was sustained for quite a long time, for almost 6 months. And then it decreased to 50% by 8 months before sort of quickly dropping off. So although we didn't have the power to consider risk of hospitalization in our data, we do have some descriptive data that could be used to sort of characterize the severity of infection. So on the questionnaire, participants listed up to 24 symptoms that they experienced during their infection, and these were then grouped into these 5 categories that were created based on their clinical significance. So at the lower end of the spectrum were the asymptomatic infections, and those are shown in the light blue. And then infections become more and more severe, the darker the color shown here. So the most severe infections were those that led to severe chest pain or hospitalization. We found that the pooled percentage of asymptomatic infections was 53% in the pre-Omicron era and 39% in the Omicron era. So these are high figures, and it suggests that throughout the pandemic, there have been a substantial number of asymptomatic infected individuals who may cause potential transmission unknowingly. And then we also saw that infection with the Omicron variant causes less severe disease compared to the previous variants. So during the Omicron period, only 1% of our study population had sort of the most severe illness compared to 7%, for example. And some of this is sort of reiterated in these histograms here, which show specific symptoms. So the lighter the color here, the more mild. If it's light blue indicates that people said no, that they didn't experience that symptom. Medium blue indicates mild, and then the darker blue indicates it's more severe. So here we're looking at the wild type variant, so that's the original ancestral strain, compared to alpha. And you can see that the wild type presented with symptoms that were more likely to be severe than the subsequent variants. So there was loss of smell and taste, which were much more common than for subsequent variants. There was fatigue, general aches, headache, and dry cough. And these were often severe. And then by April 5th 5th, 2020, so very early on in the pandemic. The dominant strain was Alpha. And this was characterized by fatigue, general aches, headache, shivering, and dry cough. These were often mild. So you sort of see less of the dark blue as we go from wild type to Alpha. And here we're looking at Delta and Omicron. So Delta was characterized by cough and loss of smell. Sorry, it was those were less common, but headache, sore throat, runny nose, fever, fatigue were common and mild. And then during the Omicron era, which began in December 2020, symptoms were relatively mild in our study population, but as upper respiratory and cold-like symptoms, runny nose, congestion, sneezing, sore throat, and fatigue, these were more common. So in addition to considering, the 4 categories that I discussed before of disease severity, we also created an index where we summed the number of symptoms and compared the number of symptoms associated with infection and breakthrough infection during the Omicron and pre-Omicron waves, depending on baseline immune status and subsequent vaccinations. So we created here these 4 categories of immune status based on serology and previous infection. So there was the group that had no immunity at all, the group that was twice vaccinated but uninfected, the 3rd group were those who were infected but unvaccinated, and finally those with hybrid immunity, so defined as those who were both infected and had at least 1 vaccination. So the hypothesis here was that pre-existing immunity, either from previous infection or from vaccination, would confer protection against more serious disease, and that the greater number of symptoms, the more severe the disease. But you can see that that wasn't entirely borne out by our data. So within each category of immune status, those infected during the Omicron period, so the turquoise box plots, reported fewer symptoms, but it wasn't a dramatic difference. So participants reported a median of 5 symptoms in the pre-Omicron period and 6 in the Omicron period. Sorry, other way around. And then the vaccinated group reported fewer symptoms than the infected group. And those with hybrid immunity, did not report fewer symptoms than the vaccinated group. So these are the sort of the box plots on the right, and that was sort of surprising. We sort of went in expecting that those with hybrid immunity would have fewer symptoms than some of the other groups. But that wasn't what our data showed. We know though from other research that at the extreme end of things, reinfections definitely seem to be less severe, such that protection against severe disease and death is more durable. It could also be that the number of symptoms associated with the reinfection depends or varies depending on what your original variant you were infected with. And other studies have shown, for example, that with an Omicron reinfection, the rate of symptoms was about the same across reinfection and primary infection. Okay, so now we're looking at symptoms according to immune status and receipt of booster vaccination. And we saw that booster vaccination was associated with the reduced symptom number, regardless of whether the individual is previously infected or not. But given our data on waning vaccine effectiveness, the benefit of booster vaccination might also wane over time. So here we're looking at some of the other risk factors for infection during the Omicron period. We found that women were at a lower risk of infection, so the hazard ratio was 0.89, so about a 10% lower risk of infection among women compared to men. And this was sort of also reflected in the antibody levels. When we looked at antibody levels and compared them between the women and men, we found that on average, women did have higher antibody levels. During the Omicron period, as we've seen before, risk decreased with increasing age. It was actually quite a marked difference. So compared to those who were under 45, those over aged 85 had about an 87% reduced risk of infection during the Omicron period. So here we're looking at the figures at the bottom. We found that essential workers were at an increased risk of infection, so about a 12% statistically significant increased risk. And those who traveled were at about a 25% increased risk, which was also statistically significant. And we saw early in the pandemic that there were some social determinants of health, like race and ethnicity, that played an important role in risk. And it was initially unclear if these inequities persisted. And what we saw was that when we considered, the full duration of the pandemic, that these inequities did not persist. So during the Omicron period, we were no longer seeing this variation in risk of infection by ethnicity. So our final questionnaire then included some questions related to post-COVID condition, sometimes called long COVID or post-acute sequelae. And it refers to a large collection of symptoms and signs experienced by patients with COVID following an initial infection. There still isn't one agreed upon definition, and some studies focus on signs and symptoms that persist for more than 1 month. Other studies have been focusing on symptoms that persist for more than 3 months. Clearly, though, this post-COVID condition, it's not just signs and symptoms that occur following COVID. They're so disproportionately prolonged and severe that they seem to be indicative of the development of a new condition following an initial infection. So in our study, the vast majority, close to 60%, saw their symptoms resolve within 2 weeks. Long COVID had a prevalence of 6% among those infected, and that's a figure that's roughly in line with some of the worldwide estimates that put the prevalence of long COVID at about 10%. So looking at the symptoms, you'll note that it can be hard to distinguish some of the symptoms due to COVID with those that could be due to another pre-existing medical condition. So the most common ones, for example, were chronic fatigue, muscle aches, shortness of breath, memory problems. So among those whose symptoms persisted, about 50% were reporting some of those conditions. We did see that those with the most serious illness, so the most serious COVID infection, were more likely to experience long COVID, but even those with mild illnesses did experience long COVID. So in conclusion, we found that more than half of the COVID-19 diagnoses were among those who neither knew nor suspected that they were infected. We found that the risk of infection increased among younger individuals, men, essential workers, and those who traveled. We didn't see ethnic differences of risk through the Omicron period. In terms of vaccine effectiveness, we noted that the effectiveness of either full or booster vaccination in preventing infection was short-term, so it only lasted about 4 months. Antibody levels were good correlates of this vaccine-induced protection, and that prior infection was a lot more robust in providing protection. So the protection from prior infection lasted about 8 months. And given what we're seeing about the risk of post-COVID condition and the fact that there continue to be some people who are at a higher risk of more severe outcomes, we really do continue to need strategies to counter this relatively short-term protection. So it would be valuable, therefore, to continue to monitor the epidemiology through testing, or wastewater surveillance, and perhaps to roll out booster campaigns and then rapidly boost population immunity before an upcoming wave of infection. So I've actually just sort of skimmed the surface in terms of the volume of data that was collected by CanPath in supporting this COVID-19 research. There are still lots of opportunities for data analysis for researchers who are interested. You can sort of peruse the CanPath portal to see the data that are available. It includes not just the COVID data, but other harmonized baseline and follow-up questionnaires. And then the process to access some of the COVID data is expedited. So I'm presenting this work on behalf of Philip, Dalla, and Kim Mesquite as well. Philip, again, is the principal investigator of the platform, the Support Canada study within which this analysis was done. Thank you also to the team at the Brown Lab, everyone at the National Coordinating Center, and of course to the Ontario Health Studies team who facilitated all of this data collection. And thank you to the sponsors and hosts of the antibody study and to all of the participants.
you very much, Vicky. That was a fantastic presentation, and it's amazing to see what we've got here with what we can do with so much data as well, and what we're learning, still learning as well. So we have a number of questions that are online, and there are questions presumably also in the room. So what I'm going to do is start with some of the online questions. Before I actually start with it, I just wanted to say that all of the data that Vicky has described, specifically the raw data, is available for research use by the research community, and can be accessed via the CanPath portal, as Vicky had just mentioned. And as well, the data, particularly some of the data that was shown in collaboration with many of our collaborators, also available through the COVID Immunity Task Force portal at McGill. So I'm going to start with one of our first questions that's coming from online before I'll turn it over to anything in the room, and then ask. There's many other questions here as well. I'm fast and furious here. So hello, Dr. Kirsh. This is from anonymous attendee, presumably number one. In the pie chart, you showed different proportions of COVID diagnosis or antibodies. There were 9% of respondents and PCR rapid test diagnosed, but no antibodies active. Is this immunity weighted?
So it could be due to the fact that either immunity waned, although the presence of antibodies seems to be quite sustained. Like even at a year, people seem to be still testing positive if they had a prior infection. It could be sort of a flaw due to the test sensitivity not being perfect, or it could just be that we got to them too soon. So it can take a couple of weeks after an infection for someone to seroconvert. So it's possible that our questionnaire went out to them during that an interval just after they've been infected, and that's why they're not testing positive.
Great. It's hard to see if there's follow-up, but we'll keep going here. So Bart Harvey has asked, did you find any effect of self-reported mask use?
So mask use was one of the variables that we didn't continue to ask. We only asked about mask use on the first questionnaire. During it was pre-Omicron when our risk of infection was really low. So no, we didn't see an effect, but I don't know that we were necessarily powered to really evaluate whether it was protective against infection, when risk was higher during the Omicron, for example. Earlier on, people were, lockdown was more common, people were staying home. So we didn't see a signal there, but I'm not sure that that's indicative of there not being an effect.
Anonymous attendee has asked, do your findings suggest that vulnerable populations should receive boosters every 4 months?
I mean, I think that that's what these data are indicating. That's sort of the paradigm that we're used to of like a flu vaccine where you get sort of one annual vaccine. It doesn't seem to be, sufficient in this case. I mean, we haven't sort of been living with COVID long enough to see what the seasonal variation is going to be long term. But at least for now, it suggests that people who want protection will need more than an annual and maybe a biannual, and maybe yes, every 4 months.
Just kidding. So we're going to keep going. Julie Perry has said, thank you for a great talk. I wonder if you can speak to how we can make decisions or model vaccine efficacy. I'm going to presume that BE there is is when a correlative protection is still undefined for SARS-CoV.
Well, I think what our data showed really is that we don't need these antibody levels. At some point early in the pandemic, it was thought, are we all going to be able to go into a lab, have our antibody levels measured, and be able to determine, yes, you're due for another vaccine, or no, you're not. And while we did find that antibody levels were correlates of protection in our data set, we also saw that it was really enough just to know when was your last dose. Like that seemed to be all we need to know in terms of being able to model vaccine effectiveness, to know whether or not somebody was still protected.
Sake of variety, we do have more questions, but I'm going to ask a question. So, so what do you think we should be doing next? Maybe from an operations side as well. Like, while the COVID Immunity Task Force has officially come to an end or proposed, we still are in the field of CanPath and always will be. Is there something that we should be still continuing to collect, or given what you've captured in terms of our analyses and results?
Well, I think research in the area of long COVID, for example, represents a future, research opportunity. We now have this, defined group of participants who we know continue to experience effects, I mean, you could contact them again. We've also shown that we've been successful at linking our cohort to administrative health databases. So we could link these participants to some of the administrative databases to see what some of the long-term effects are, whether, neurological effects or cardiovascular effects. So I think long COVID is one potential avenue for research. I mean, we also have funding to look at some of the genetic risk factors for, for risk of infection or risk of not seroconverting, for example. So we can use some of the dry blood spots that have been collected. Those are good sources of DNA, and sequence participants and see if there are any genetic risk factors.
Yep. Great points. Anonymous attendee, do we know how long after infection levels of IgG remain detectable?
Right, I think so. So that's actually another area of research that we could revisit. It was something we looked at earlier on, and we saw that it was pretty robust. Like within a year after infection, we were still seeing positive anti-IgG. But that's definitely something that we could look at again now that we've sort of have 3 years out of the pandemic to see if those levels continue to be elevated.
Jason Zhu, thanks for an excellent presentation. Could you propose any hypothesis for the mechanism of prior infection posing a stronger and longer protection than vaccine-induced effect?
Well, I mean, we know that vaccines are generating, neutralizing and binding antibodies, but that there's, our innate immune response is sort of much more complex. We've got B cells and T cells, and it could be sort of those other aspects of immunity that are conferring additional protection that's beyond what vaccines alone can do.
What is the anonymous attendee? What is the generalizability of this study findings to the general Canadian population?
Well, I mean, I think it's directly generalizable to the Canadian population. This is sort of a representative sample of the Canadian population. And it includes, and we've adjusted for sort of people with age, for comorbidities. So we've taken sort of the variation within the Canadian population into account. But I would say that, this is the best, most representative population that we have.
Couldn't agree. Anonymous attendee, is NACI aware of all of this information?
Right, so we continue to sort of communicate our results with them. We're sort of working on a preprint, a manuscript, which will, sort of hold more credence. But yes, we do continue to communicate our results.
Lynn Johnson has asked 2 questions. Are you able to determine if there's an immunity benefit to receiving different brands of mRNA vaccines, and if so, was it?
So when comparing the mRNA vaccines, we were seeing a benefit of Moderna compared to Pfizer. When we looked at sort of what the most recent brand received was. Earlier on, as I mentioned, we were seeing that those who received AstraZeneca weren't mounting as high antibody levels compared to those who received mRNA vaccines. But now there's a question that some people are asking, well, because of this issue of immune imprinting, is it possible that the people who received AstraZeneca early on, could they have more robust immunity now because they have this heterologous vaccination? And that's something that needs to be explored. So some of these analyses, I should now stratify, by the product received and see if there's variation.
I'm going to ask maybe this is a bit of a tricky question. So you mentioned in one of your slides that there's clearly an antibody effect, and we're only looking at a subset of antibodies. If you were to guess, we still are waiting on analyses of neutralizing antibodies. What do you think the impact might be there? What might be the impact be observing or seeing?
Well, I mean, studies have shown that neutralizing antibodies are very good correlates of these binding antibodies, but because they more directly neutralize the virus and render it ineffective, if I were to hypothesize, I would say that that they're even stronger mediators of this vaccine number effect. And then it will be interesting too to see whether or not how the antibody level, the neutralizing antibody levels vary between those who receive the bivalent vaccine and those who receive the monovalent vaccine.
Thank you. And I think this is going to be our last question. And I'll just point out before asking this, the webinar will be posted pretty soon, I imagine, within weeks anyway. And so there'll be an opportunity for the community to potentially address or engage us as well with any questions that may be arising. So a couple of more questions here. Anonymous attendee, given the level of asymptomatic transmission and reduced effective vaccines for preventing infection, especially after 4 months, what do you recommend for people who are trying to avoid infection, especially if no prior infection? So we'll start with that.
I mean, you know, the most important thing seems to be to receive another booster vaccine to try and sort of keep on top of rates in the population and when they're peaking, and to get another booster vaccine, you know, before an upcoming wave. You know, and although our data wasn't really equipped to analyze it, it's still, other studies have suggested that these preventive measures like mask wearing really are effective. You know, so that would sort of be another important preventive measure that we can take.
Yes, and so that person's also, it's getting very hard. Hard Harvey again, is vaccine uptake in this cohort similar to the general public?
It was a little bit higher. So there was an earlier slide where you could see that only was less than 2% of our study population was unvaccinated. I can't remember how that compares to the general vaccination, but I know that it's lower. I mean, this is a study population is interested in research, and so it sort of follows that they be more likely to be vaccinated.
We are told to speak up a little louder here. So, subunit protein vaccines offer robust protection. Should Canadians receive future boosters that are non-mRNA to have heterogeneous vaccinations?
Right. I mean, so that's the theory to sort of get around this immune imprinting. I mean, there have been lots of research. There's been lots of research from influenza vaccine. But even still, I mean, even with all the research that's being done around influenza, we still don't have a universal influenza vaccine. So I'm not sure that in itself will be the answer. But there's some thinking that it doesn't necessarily have to be a non-mRNA vaccine, but maybe rather instead of vaccinating with the entire spike protein, to choose sort of a smaller epitope so that sort of it doesn't, you know, detract from the immune response in general. So the idea is that maybe instead of vaccinating with the entire spike protein, to just choose maybe a subcomponent like a part of the receptor binding domain. That's what some of the current research has said.
I'm going to ask this last question. I know I said the previous one was going to be the last one. I think this is an important question. So is it possible this cohort has a differing health profile than the Canadian population?
I mean, in terms of, it's possible. We do try to take those things into account in our analysis. So we controlled for comorbidities, we controlled for preventive measures and travel taken and occupation. So although they might not be identical, I think that we've sort of been able to statistically adjust for some of those differences such that our results would be generalizable.
Thank you very much, Vicki. So I'm going to thank Dr. Kirsh once again. It was a fantastic. Once again, thank you all for attending. Thank you for joining us live here for those who are here live, and thank you again for joining online to those who we had a great turnout, and so very appreciative that you've been able to come and listen to this work. So thank you very much.